with you a presentation called documentation and handover practice. This might look very simple, and yet not many people practice it correctly, and sometimes they often neglect this aspect. So I will divide my presentation into two parts, which is part one is about documentations. So I will talk mostly about the clinical notes and also the SOAP notes, and next I will discuss regarding the handover process. And this handover process, I will introduce three things to you. The first one is when you are about to request help and you have a single victim with you, then you can use this ACMIS mnemonic. Let's say that you are dealing with a mass casualty incidents and you need to send a report regarding the incidents for the purpose of disaster activation. Then a methane mnemonic will be used. And finally, I will talk a bit on the SBAR procedure for the handing over. In vigilance and remote setting, documentation may become the only medical record available during the evacuations. Proper documentation improves continuity of care, communications, patient safety, and also medical legal protection. The documentation is especially important when the evacuation is delayed, multiple rescues are involved, or prolonged field care is required. Poor documentation may lead to repeated interventions, medication errors, misdeterioration, or failed handovers. So why documentation is important? Number one is to track patient progression and deterioration. Secondly, it records the treatments and medication given. Third, it assists in evacuation and retrieval teams. Next, it improves communication between the rescuers. Then it supports decision making during the prolonged care. Apart from that, it also provides medical legal protection, and later on it will be useful for debriefing of the end of the training. Recording the documentation in the remote setting or wilderness setting can be difficult. Number one, especially during the darkness, rain, or extreme weather. Sometimes our paper can be damaged by the environmental factors. And if we bring along tablet or anyways to record on the electronics, sometimes the battery may run out or the electronic can be malfunctions. And this is also can be made worsen if you don't have energy supplies to charge your phones, right? Apart from that, people are not really into writing documentation because they are already tired, and the situation causes them a lot of stress. They feel overwhelmed, and they think that they need to take care of multiple things. So this is why, if you actually have many responders or rescuers during that time, you can assign a person to be in charge of documentations. And again, even if you have that, but in the wilderness, if you are dealing with multiple casualties and chaotic scenes, this might create confusions and also give you lack of motivation to write documentations. The longer the evacuation and the prolonged the incidents, the more things that you need to write, and this can be very tiring. And finally, if you are about to convey a message through the radio, it can be a difficult communication and also radio failure as well. In a case note, you should document particularly few things: the patient identification, the time and mechanism of injury or illness, what are the initial findings and vital signs, the treatment and medication that was given. If you are about to see the patients multiple times, then you should record the changes in patient conditions, whether they are improving or getting worse with the treatment. Inside the documentation, you should also put on the evacuation decisions and also the timelines. And of course, any communication with medical control or rescue team should be documented as well. So in remote medical setting, as I mentioned before, this can be written in a form or through the electronic notes. The clinical notes should be confidential, not to be accessed by everybody, but the content may be used for teleconference or referral process. So this is the example of case note that is being used at the medic base, right? So the first part, you put on the patient details, the backgrounds, then next with the chief complaints, followed with your observation and also examinations, vital signs, and you put there the impressions, right? And after that, you can put there your plan for these patients. And this should be having signatures and also your designations. Another form that we use in wilderness is the SOAP notes. Basically, SOAP note is a structured documentation method commonly used in wilderness and prolonged field care. So it has four components. The first one is the subjective. So subjective is basically what the patient says or complains about. Objective is about finding observed by the rescuer. Assessment is basically the rescuer's impression or work diagnosis. And finally, for the plan, this includes the treatment monitoring and also the evacuation plans. So this is the examples of the SOAP notes that was provided by the ones Malaysia. So at the top of the documentation is the patient demographic. Then it goes into the subjective. You need to put there what are the symptoms involved, whether it is a lightning strike, whether it is fall from heart, or whether this is cases of suspected drowning. Then you put the sample history, the one that we teach you during the patient assessment system. This includes the symptoms, allergy, medication, pertinent, last in and out, and also the events. Then after that, we go to the objective. So this objective assessment includes the head to toe examination and also the vital signs. Then after that, it goes to your assessment and also your treatment plan. And of course, you need to put there also your ongoing monitoring and also evaluation plan, as well as the additional notes. At the bottom of the forms, you should put your name, the contact number, the time of handover, the date of handover, where the handover took place, and who received the handover of the patients. So this note ideally should be prepared in two copies. One is to be given to the EMS that is taking over the patient, and another copy should be checked with you or the wilderness EMS providers that you are working. If in case that in the future, if there is any legal disputes or something that you need to clarify or for the purpose of audit, then you can refer to the notes later on. Next, we go with the handover. Why do we need a structured handover? This is because the effective communication with the patient handover is a critical component of emergency medical care. The transition of care from the pre-hospital care providers to the immediate trauma department is often the first and most vulnerable link in the chain of hospital-based management. So any delay or failure in the process has been associated with clinical errors, omission of key patient information, compromised patient safety, as well as adverse outcomes. Clinical handover in emergency setting is not merely a transfer of tasks, but it is a complex interaction that will affect the continuity of patient care, the team coordination, the trust across care levels, and in trauma cases, the quality of handover directly impact the triage decision, activation of trauma team, and prioritization of diagnostic or procedural actions within the golden hours. Handover communication is one of the top 5 patient safety priorities. The WHO recommends the use of standardized tools such as the SBAR or IMIS AMBO. The structured handover tool has been shown to reduce communication breakdown and ensure that clinical patient information is consistently transferred between teams. Right, so here is the recording conversation between the field medic and the medic base. This is about ADMIS passover, which is a structured communication for clear and effective information transfer during the patient handover. So you should note that the ADMIS stands for A is for the age of the patient, T is for the time of injury of the onset, M is for the mechanism of injury, I is for the injury sustained, S is for sign and symptom, and finally T is for the treatment given so far. So this passover should be given in a clear communication so that a better decision can be made for the better outcome of the patient. So you need to give not a lengthy of information, but rather it is a concise, but having the right information so that you can have the right support and this will be delivered at the right time. So let us listen to the conversation.
This is Alpha Team. We have one trauma patient requiring evacuation. Copy, Alpha Team. Please proceed. AT MIST handover follows. Age, 26-year-old male. Time of injury, approximately 40 minutes ago. Mechanism of injury, fall from approximately 6 meters down a rocky slope during jungle trekking. Roger that. Please proceed. Injury sustained. Suspected right femur fracture, possible pelvic injury, blunt chest trauma, and multiple abrasions over face and upper limbs. Signs and symptoms, patient initially conscious but becoming progressively drowsy. Current AVPU score responding to verbal, heart rate 132, blood pressure 88/54, respiratory rate 28. Oxygen saturation 92% on room air. Patient pale, diaphoretic, and complaining of severe pelvic and thigh pain. Roger that. Please proceed. Treatment given. Cervical spine manually stabilized. Pelvic binder applied. 2 large bore intravenous lines secured. 500 milliliters warm crystalloid administered cautiously. Tranexamic acid 1 gram intravenous given. Patient placed on oxygen via non-rebreather map. Terrain difficult. Estimated extraction time approximately 2 hours. Roger that. Please proceed. Requesting advanced retrieval support. Copy, Alpha Team. 26-year-old male. Fall from height. Suspect pelvic and femur injuries with signs of hemorrhagic shock. Continue permissive hypotension. Strategy. Minimize patient movement. Retrieval team preparing deployment now.
This is Alpha Team. Right. So next let's discuss about the mid-10 passover. This is a list of information that is needed basically during a disaster, but it can be applied for the wilderness mass casualty incident as well. Right. So it consists of few things that you need to convey. The first one is whether the major incident has been declared or not. So if the major incident has been declared, this is usually need to be explained regarding the nature as well as the type of incident. So in Malaysia, the major incident are usually declared by the police. E stands for the exact location. T is the type of incident that happened. H is any hazard that might affect the responders and also victims. A stands for the access, which is the route for the entry points and also the exit points. N is the numbers of casualties. And E is for what are the emergency services that are already available there and what services that you need or what are the equipment that you need. So the information needs to be clear and concise so that the control base or the medical base, they can coordinate a response, especially between the interagency. And this will lead into a better outcome for the disaster or mass casualty management. So let us listen to this clip on how mid-10 passover are being conducted.
Kanabalu Base. Kanabalu Base. This is Dr. Jack from Syed Team. Do you copy?
Dr. Jack, this is Dr. Maria from EMS Call Center. Loud and clear. Go ahead. Go ahead with methane.
Dr. Maria, this is currently not an officially declared major incident yet, but we are dealing with a possible mass casualty situation following a lightning strike.
Roger that. Please proceed.
Methane pass over follows. Major incident, possible major incident, not officially declared at this moment. Exact location, Syed checkpoint, Mount Kinabalu. Type of incident, lightning strike involving climbers during storm activity. Do you copy?
Roger that. Please proceed.
Hazards, ongoing rain. Risk of secondary lightning strike. Cold exposure and poor visibility. Access only possible by trekking route. Potential helicopter landing may be possible near Panalaven helipad depending on weather conditions. Number of casualties, estimated 20 patients involved. Several unconscious. Multiple burn injuries and possible cardiac arrest victims. Emergency services required. Additional mountain rescuers required for casualty evacuation. Requesting resuscitation equipment. Advanced medical support. Stretcher teams. And possible helicopter evacuation support if weather improves. Copy EMS call center. Reverse triage and resuscitation currently ongoing.
Copy, Dr. Jack. Possible lightning strike mass casualty incident at Sayat, Mount Kinabalu. Approximately 20 casualties. Access via tracking route only. Helicopters stand by to assess weather window. Near Panalaven helipad. Mountain rescue teams and medical assets are being mobilized now. Please continue scene safety assessment and casualty triage.
We'll update casualty numbers once assessment completed.
Understood, Dr. Jack. EMS Call Center, stand by for further updates.
Right. If you notice that in these conversations, the field medic, they did not give the whole information in one breath. So meaning that when you are conveying the message, it should be concise. And then number 2 is that it should be clearly been explained. And thirdly, try not to frame everything in one sentences or in one breath, but rather try to divide the information into a multiple part. So this will enhance the understanding. And furthermore, when you are conveying message using a radio communication or maybe a phone call, you need to understand that sometimes the communication might be disrupted or the line is not there. So some information may be lost during the process. And it is also important when you are conveying the message, the people who are receiving the passover can repeat again the message that you conveyed. So this will ensure that the message has been received and they will take action on what are the things that you requested or conveyed to them.
Kanabalu Base.
Right. So finally, we are going to discuss on the SBAR passover. So this is usually a situation background assessment recommendation. It is a structured communication for safe and effective patient handover. So this is usually between a treating doctor who is about to transfer the care of the patient to another responder or to another doctor. Right. So basically, the S is the situation. You are basically introducing yourself and explaining that you are going to hand over a patient. You can then proceed with the B or the background, in which that you provide the brief relevant history and event that you are hoping the receiving team will provide to your patient? Is it in the form of investigation or treatment, or what are the level of care that the patient needs? So this SBAR should be handed over using a clear communication. So the reason is that to ensure the safe care for the patients and hence lead to the better outcome. So now let us hear this conversation between the field medic and also ambulance crew.
Hi, I'm Dr. Jack, Wilderness EMS physician. May I hand over this patient to you?
Hi there, I'm Amelia, paramedic from Hospital Lahad Datu. Yes, Dr. Jack, you may proceed.
I've had a 40-year-old female with suspected heat exhaustion, progressing toward heat stroke. Critical long-term lag. Patient involved in hiking expeditions in Stormway. Minimal fluid intake. Found infused and unable to walking approximately 1 hour ago. On assessment, he's conscious but responding to force. Only. Patient's hot to touch. Heart rate 124. Blood pressure 160. Respiratory rate 26. Temperature estimated above 39 degrees Celsius. Patient nodding and intermittent infused. Weak radial pull. Noted. No major trauma identified. Our condition is patient requires urgent cooling, IV, fluid resuscitation, electrolyte assessment, and transfer to hospital for further management.
Thank you for your hand over Dr. Jack. We'll continue active cooling and prepare transport. Is there anything else you want to add?
Oh yes. Patient received oral electrolyte solution before vomiting and cooling started 20 minutes ago. Measures.
Understood. We are taking over patient care now.
Hi.
Right. So we already covered about the clinical case note and also the communication process for handing over. So with that, I end my presentation. Thank you for listening.